Hi everyone, my name is Robin. I'm the Programs and Advocacy Manager at Inherited Cancers Australia. And I wish to start by acknowledging the traditional custodians of the land that we are on today. And I'm here in Canberra, so on beautiful Ngunnawal country. I want to pay my respects to elders past, present and emerging. And Professor Andrew Metz, who's talking to us today, you are on different lands. Where are you?
Kulin Nation, I think, in Melbourne.
Wonderful.
Yeah, Wondery.
So many of you will know that at Inherited Cancers Australia, we support, educate and advocate for the 1 in 400 people who have inherited cancer risk. So either gene mutations that predispose them to cancer or people that have a really strong family history of cancer. So today we are talking about pancreatic cancer and risk. There are several gene mutations that are associated with a higher than general population pancreatic cancer risk. So such as BRCA 1 and 2, CDKN2A, PALB2 and ATM, just to name a few. And many of you will know that November is Pancreatic Cancer Awareness Month. So today we're going to be talking to an expert whose work is focused on pancreatic cancer research, specifically around that early detection and screening, which is super important for people in our community. And often we do hear in our community that because the signs and symptoms can be a little bit vague and there's no current validated screening for pancreatic cancer risk, and the outcomes for pancreatic cancer are not great. People in our community often talk about it and can be worried about the risks. So today we're talking to the wonderful Professor Andrew Metz about the APRISE study and how it relates to those with inherited cancer risk, particularly those with BRCA 1 and 2 or PALB2. And we're going to talk about why this research matters and how people can get involved. So I'm going to start by introducing Professor Metz. So thank you very much for joining us. Are you okay if I call you Andrew, or are you?
Absolutely. Yep.
Wonderful. Professor Andrew Metz is a gastroenterologist and an interventional endoscopist. Professor Metz underwent gastroenterology training at the University of Melbourne and the Royal Melbourne Hospital, where he graduated with honours. He then undertook a fellowship in therapeutic endoscopy at Westmead, where he focused on endoscopic ultrasound with endoscopic mucosal resection. Andrew's main research interests are in bowel and pancreatic disease, particularly in early detection and screening in pancreatic cancer and novel endoscopic treatments. So Andrew's the director at the Jreissati Pancreatic Centre in Epworth, leading the Centre of Excellence in Research, Clinical Care and Patient Experience for people with pancreatic cancer. He's on the Council of the Australian Pancreatic Club and the Australian New Zealand Endoscopy Leaders Forum. And Andrew is also the Director of Endoscopy at Royal Melbourne Hospital and was previously a Director over in Cambridge in the UK. So welcome. Wow, what a bio.
Thank you very much for having me, Robin. I'm always happy to talk about the pancreas, which often doesn't get much press.
Yeah, absolutely. So tell us, I guess we'll start off. So pancreatic cancer is known as one of the hardest cancers to detect early. So why is that?
Look, the problem with pancreatic cancer, Robin, is that it often presents with sort of vague or nondescript symptoms. So for some people, it can be a little bit of heartburn. Some people can be a little bit of bloating or loose stools, and some people can be some back pain and weight loss. And for that reason, patients have often seen their GPs between 3 and 6 times before the diagnosis of pancreatic cancer is actually made. Now, that's not a criticism at all of GPs. 20% of what they're seeing are those sort of symptoms, and only one of those people for the entire year is going to have pancreatic cancer. But it goes to show it's really a needle in the haystack for GPs. So really the key around it is that we need to have a high degree of suspicion but to really try and shorten the time between symptoms and diagnosis being made. But I think really what it shows is it's difficult, and what we're doing at the moment is not working for patients.
Yeah, right. Yeah, those they are very kind of vague symptoms, aren't they? That could be kind of associated to many things in life.
Absolutely. A bit of reflux, a bit of irritable bowel. And for the majority of people, it will be reflux and irritable bowel. And that's why it is really difficult for GPs to find this. And we're doing a lot of work on trying to help them with risk stratification tools. But all this sort of stuff is underway. And if we actually look at it, that, you know, a quarter of patients, it's 120 days before their diagnosis is made. So it's not surprising by the time their diagnosis is made that only about 20% of them can actually get to surgery. And that's really what we're focused on, changing that story to try and improve early detection. And part of that really is screening. So finding these things before symptoms actually develop.
Yeah. Yeah. Wow. That's a lot.
Mm.
Not a lot of people,
Mm.
getting a diagnosis early, which is no good. So pancreatic cancer risk, can it be inherited? And which gene mutations are most commonly linked to inherited cancer risk?
Look, the most important thing to say, and I know you have an interested audience here in regards to inherited cancers, but the most important thing to say about pancreatic cancer is the majority is not inherited. So about 85%, there is no family history, and it's related to lifestyle factors. And obviously they're important to talk about whether patients have gene mutations or not. But for the majority of people, they're not particularly at risk. So about 15% we do believe does have an underlying inherited risk, and some of the gene syndromes that you've talked about clearly increase the risk of that. But also a lot of there's clearly familial pancreatic cancer. And what we know about that is that for the majority of patients, if you've got one family member, if we look at population studies, your relative risk is probably not particularly higher than average. But once you start to get to 2 or 3 family members on the same side, then the relative risk goes up dramatically. And what we assume is that there's an underlying inherited or genetic risk in those families, but we just don't know enough about it. So really who we need to target are the gene syndromes that you've described, but also patients whose family is highly suggestive that there's an inherited risk there too.
You talked, you touched on lifestyle factors there that can increase your risk. What are those?
So look, the biggest 3 risk factors for pancreatic cancer are smoking, being overweight, and diabetes. And diabetes is an interesting one because diabetes does increase your risk, but also we know that for patients with pancreatic cancer, the vast majority of them were given a new diagnosis of diabetes within the preceding 3 years as well. So whether you're fit and well, or whether you have one person in the family, or whether you have one of the syndromes that you've previously described on this discussion, really focusing on those factors is really important. And even in those with a genetic risk, we do believe that that those factors increase the risk again. So clearly avoiding smoking, clearly keeping a healthy weight and eating well, and looking for and managing diabetes if it's present.
Yeah, okay. Oh, it's very good to know.
And diabetes is really interesting. We know that the pancreas, one of its jobs is to make insulin. So clearly with a diagnosis of pancreatic cancer there, quite early on, we do see development of diabetes or previously stable diabetes becoming unstable. And that's another area of early detection that we're looking into working on as well, because an interesting American study did show that for patients who newly diagnosed with pancreatic cancer, the vast majority of them had changes in their insulin within the preceding 3 years.
Wow. Very interesting. You touched on before, I can't remember if you said 1 person every day, but how common is pancreatic cancer?
The bottom line in Australia, it's not common. We get about 5,000 a year for the entire nation. So look, it's not certainly not one of the most common cancers. The problem with pancreatic cancer is that it's one of the most deadly. As you know, there've been fantastic changes and advances made in screening and treatment of things like breast cancer and bowel cancer. So now that we see, even though they're more common, that patients are actually doing much better. The problem with pancreatic cancer that it really hasn't had those huge wins, those big early detection and management changes over the last few decades, and really, unfortunately, therefore, there haven't been really good improvements in outcomes. And for that reason, even though it's not common, it's actually the 3rd biggest cancer killer in Australia, and it's predicted to be the 2nd biggest cancer killer by 2030. And that's why we're so focused on changing that. Look, it's a combination. One, certainly it's the incidence is increasing because, as you say, diabetes and obesity. But secondly, that we haven't improved outcomes. So whilst things like breast and bowel may be more common, the actual likelihood of cancer or cancer dying from that particular cancer is much higher in pancreatic cancer. And it is currently the 3rd biggest cancer killer at the moment, simply because we haven't really managed to make those improvements in regards to outcomes like it's been seen elsewhere.
And can you tell us about general population risk versus someone with an inherited gene mutation?
Yeah, so look, they're tricky to work out, but what we do know is that for some of those genes you described, the cancer risks increase exponentially. So some things, like you said, as in BRCA, maybe 6 to 10 times, and leading into things like familial pancreatitis, things like PRSS1 and SPINK1, maybe up to 40 times the
Wow.
population risk. That being said, what's really important to know is relative risk is the amount more likely that you are compared to the average population. So a big number times a small number remains a small number. And
Yeah,
the
yeah.
majority of people with things like BRCA will not get pancreatic cancer. And we know that things like BRCA, there are other modifiers that clearly play a role, because we know that there are some BRCA families who have a lot of pancreatic cancer, and there's some BRCA families who have
Yeah,
very little pancreatic cancer. So
yeah.
a lot of work's been done on this. Is it related to lifestyle? Is it related to something in that particular BRCA itself, or epigenetic? But certainly we know that for some of the syndromes you described, like the breast cancer syndromes and the bowel cancer syndromes, we don't start to get as worried until we realize that there are pancreatic cancers in those
In the
particular
family.
families themselves.
Yeah, okay. We touched a little bit earlier on screening and early detection. So why is screening such a challenge in this area?
So the reason that it's really taken this long to launch is the pancreas is quite hard to find. So it sits
Yeah.
it's behind the stomach, and it's not easily accessible in the way that some other cancers are. But some advances that have been made over the last sort of 10 to 15 years, improving resolution with MRI scans, but also the advent of
Mm,
endoscopic ultrasound. So what's endoscopic ultrasound? Well, a
mm.
lot of people online will probably know what a gastroscopy is, because many of them or their family members will have had one. Thankfully for us, the pancreas sits behind the back wall of the stomach. So if we actually sit an ultrasound probe in the stomach via a gastroscope, we can be right up against the pancreas and put the probe up and down the pancreas itself, and we can actually see lesions down to millimeters in size. And furthermore, during the same procedure, if we see something that makes us concerned, we can actually, all under real time, under imaging guidance, stick a needle through the back wall of the stomach into the pancreas and take a sample of tissue that we call a biopsy. So these has really changed how we can diagnose and confirm the diagnosis of pancreatic cancer, and because this
Mm.
can all be done as part of a day procedure in the same way that someone might get a gastroscopy.
Very cool. Wow, that's
Mm.
some amazing science. Very
It
cool.
is. And the thing is, we know, as you said earlier, we don't have a confirmed screening program. We don't have a huge amount of data to demonstrate mortality benefit in the same way as we do with breast and bowel. But the reason is
Mm,
that we're only starting to look into this. But what do we know? As you described, there are people who are at risk, but we also know the earlier we find things, the better. So if
mm.
we look at things like waiting for symptoms, only 20% get to surgery, and only 13% last 5 years. But what the Americans have found, and they're about 5 years ahead of us, there's when there's a lesion found at an earlier stage, so ideally less than a centimetre in size, the survivals increase dramatically. And what the Americans have shown is for those detected in screening, more than 90% get to surgery, and the median life expectancy is 10 years, as opposed to 20% getting to surgery and mean life expectancy being a year and a
Mm,
half. So
mm.
even though we don't have a huge population level data yet, we do know who's at risk, and we know the earlier we find things, the better, which is why we're so keen to set up the national screening program.
Yeah. So you're the coordinating principal investigator of the
Mm.
APRISE study. Tell us about that. Tell us about what's involved and what you're hoping to achieve through this work.
So we're the only country really where we've looked at setting up a national screening program. And what it involves is that people who are at risk, and you can obviously inform your listeners, but the ones, exactly the ones we talked about, certain cancer syndromes, like the breast ones with a family history, as well as
Mhm.
strong family history, so what we call familial pancreatic cancer. So if you are at risk, and we do have a risk calculator, or even just the ability to contact us to talk about it, if you're at risk, then we'd be very keen to get you into the national screening program. What does it involve? Well, contacting the Jreissati Centre. We're running the national program through the Jreissati Centre here in Richmond, Melbourne. But if people are eligible, then clearly what we want to do is, one, take some blood so we can get some genetics for these families that we really strongly believe do have an underlying genetic basis for them, and then look at doing annual screening. Why is it annual screening? Because we believe that things happen over a shorter period of time. So some of the American data suggests that lesions or biochemical or clinical changes may have happened up to 3 years before the actual diagnosis is made. So we believe there's this window where we can really make a difference. So our plan is to annual EUS or MRI. In a country such as Australia, we're very open to either. Clearly, we've got regional and remote parts of Australia. Not everyone has access to endoscopic ultrasound. But what has been fantastic is we've had huge enthusiasm from pancreatic gastroenterologists and surgeons around the country. We actually now have 30 centres around the country. So from up in Mackay down to Townsville, down to Tasmania, and from Newcastle across to Perth. So our plan will be that you contact the centre, but we'll be able to refer you to your closest local centre to try and make things as painless as possible.
Yeah. And you talked about, so if people have a gene mutation, maybe such as BRCA or PALB2, and then also have how many? So 2 or 3 other family members?
No, so if you've got a gene syndrome, that's different. So for anyone with a gene syndrome, you just need one first-degree relative, because that suggests that your gene is primed and that you would be at a higher relative risk. It's the families where there's no known gene, and they're the ones where we try and reassure those who maybe just have a grandparent or something like that they're probably unlikely to be at increased risk. But it's the ones where there's 2, 3, 4 members of the family where it really does seem like there's a familial pancreatic syndrome happening in those families. They're the ones that we're keen to tackle as well, even if there's no known mutations in those families.
So Andrew, tell us, give it a plug. How do we contact you, and how can people find out more about the study?
So we're open to all comers, and what I mean by that is patients can be referred by GPs, patients can be referred by their GI specialists or their local familial cancer clinics or genetic specialists, but they can also, them or their families can contact us themselves for a risk assessment. The number to call is 0418 370 684, or certainly email on ec-aprise, APRISE at epworth.org.au.
Awesome. And are there any costs associated to it?
So look, the program itself that we've set up is obviously paying for the study itself, but in regards to MRI and EUS screening, they're done locally. So clearly there's no cost if they're done through the public system, but if you're wanting the things to be done in the private system, there may well be costs involved. Some places bulk bill their procedures and their radiology, and some don't. So it really is a little bit dependent on the local situation, but certainly we have more than 20 public hospitals involved. And clearly, if there are costs or any concerns, then we would refer locally to the public hospital to do things through the MBS.
Oh, yeah, of course. Are there wait times, because this is kind of screening rather than kind of, diagnosis, or?
Yeah, and it's a very good question. And there are different wait times at various hospitals around the country. If there are going to be issues in regards to trying to get in for endoscopic ultrasound locally, then clearly what we would do would be trying to organise MRI. And if anything was positive on the MRI, we would quickly get you in for an EUS to organise the biopsy. Because that's really the difference between EUS and MRI. MRI is got great resolution and it can find lesions, and clearly not invasive, so no real risk involved. Endoscopic ultrasound, it has better resolution. We can see things that are small and also do have the ability to biopsy, but clearly requires an anaesthetic, and there are small but real risks involved. So that's why we've left it open to a country as huge as Australia to see if we can work out the most efficient way, depending on where patients live and what's available in the local healthcare network.
Yeah. And so for people that sign up and, the data that's collected on them, so how is that data used, and will participants then hear about the study's progress or what's happening?
Absolutely. So what we need to highlight is that the APRISE study is an Australian study based on the roadmap. We were keen to demonstrate that a national screening program could be done at the Australian level, and clearly there will be the data will be held in Australia, and ongoing assessment, so regular analysis of that data will be done with the real aim of eventually being able to demonstrate its effectiveness and being able to hand back onto government to run this in the future, in the same way that things have happened with bowel and breast cancer screening. But what we're also doing, because it's a tumour that is rarer than some of the other ones, we've linked up with the international system. So there's PROCEED, which is an international consortia who are doing exactly the same as we are here. There are 40 sites around America, around Europe, and around the Middle East who are doing what we're doing, and we will be sharing anonymized data to really increase the numbers and be able to demonstrate outcomes and as really risk assessments as well. So it is an Australian study, but in regards to looking at outcomes, we are sharing de-identified data internationally as well, which I think is really exciting.
Yeah, that's very awesome. It would be super exciting to start to see the sort of patient outcomes that come along with those population-wide screening programs that you're kind of trying to get to for pancreatic cancer.
Absolutely.
So what would a final message that you might have to share with those that maybe feel a little bit anxious about their pancreatic cancer risk and want to stay informed and empowered about it?
Yeah. So look, it is, I mean, a lot of people obviously listening today have got a gene syndrome or have watched a family member die, and obviously it's very, very distressing. And for many of those, it was, by the time of diagnosis, there wasn't much can be done. So I understand there can be a lot of anxiety around things. And certainly when you look at the situation of where pancreatic cancer is at the moment, it does all seem a bit upsetting. But what we really feel like is that there's change happening. And for the first time, if you look at 5 years ago, the third biggest cancer killer in Australia only attracted 4% of research funding and barely any publicity. But things like today's discussion and things like the launching of the APRISE study have shown that it really feels like there's now some momentum to try and do with pancreatic cancer what has happened with the other cancers, the big successes that we've seen over the last few decades. So my message would always be, there is a hope on the horizon. We really do feel like we're now trying to move the needle in regards to screening, early detection and treatments, and hopefully we'll be able to keep everyone updated as to fantastic progress that's been made over the next 5, 10, 15 years. So it does feel like hope is on the horizon.
Yeah, so good, so good. And so I guess just summing up for people who are part of our community that have gene mutations that are related to pancreatic cancer. So that's your BRCA1, BRCA2, PALB2, and now I can't remember the rest of them.
Yeah.
What
So
are the
ATMs,
other ones?
so
ATMs.
Pearl-Jaggers, ATMs, and Lynch syndrome, as well as the family history. I think what's important to say is obviously there are some conditions like Pearl-Jaggers where we want screening no matter what, and there are others like the PALB2s and the Lynches where we can hopefully reassure you if no one in the family has pancreatic cancer, but clearly if you're one of those gene syndromes with pancreatic cancer, then we would be really
eligible.
keen to have you as part of our screening program.
Awesome. Great. And obviously we'll put a link where you can find information about it and how to contact you guys in the notes. And I guess I'll just finish up by saying, at Inherited Cancers Australia, just remember that we have got moderated private online support groups. We've got peer support mentors. We've got an online genetic counsellor. Lots of information and resources like, you guys are listening to now. We've got information support days and education events. So please stay in contact with us, try to get as much information as you can, because obviously there's lots of complex decisions to be made when you're a part of this community. So keeping informed is obviously really great. So I just want to say thank you very much, Andrew. It's been great to pick your brain about what you're doing in the APRISE study. And I really hope that people that are listening, have chats about their family cancer history and talk to their local health professionals and see if they can potentially, jump on the study if it's relevant to them.
Well, thank you very much for having me today. And absolutely, we'd be keen to hear from anyone with any concerns, and hopefully we'll be really able to do some good.
Awesome. Thank you.
Thanks very much.